Good evening, everyone, and thanks so much for coming out tonight to be here. Let me first take care of my disclosures of potential conflicts. I have had research support from the Robert Wood Johnson Foundation for a program I will be talking to you about around early intervention for young people with early signs of serious mental illness, and also funding from the National Institute of Mental Health for a program called RAISE. In addition, I've been on advisory boards for the Robert Wood Johnson Foundation and actually for our National Center for School Mental Health at the University of Maryland. I work in our Stanford Psychiatry and Behavioral Sciences department. We have really a 5-component vision in our department, and I really represent to a very large degree our community engagement component. We've really come to believe in the very strong importance of collaboration with community partners, and we're working hard to build that effort in a number of different ways, and some of them will be reflected in our discussion this evening. So as I speak to you tonight, there will be a couple of components to frame our discussion. I want to initially talk about mental health as a public health issue and why it's important we think about it in those kinds of broad terms, and then why there's more of an interest in looking at early detection and intervention for what we're calling psychotic illnesses. We're going to then jump to some of the international work that's happening that is really very exciting and quite dynamic in terms of building supports for young people with very early signs of mental illness, and then talk about what our country's beginning to do and then what's happening here locally as a response to that and the models that are being developed in this area as well. So when we talk about initially issues of mental health, what's important is just to remember that mental health is a worldwide public health issue. And in fact, depression is rapidly becoming the leading cause of disability in the world. And it's expected to be the #1 cause of disability by the year 2020. So mental disorders are a huge component. However, many people don't have a good sense for them or talk about them in great detail because, as many of you know, the stigma issues are huge. I want to make a quick comment in that direction. I come from a family where within every generation around me, there's at least one member of our family that has been facing a mental illness. And I think probably most of you would be able to acknowledge, if the world was a little bit of an easier place sometimes, that that's probably true for most of you as well. You know, we're in a world where I might be able to ask you how many people here have diabetes or how many people have high blood pressure, but we really aren't at a place where I can say how many of you have a mental illness. And our hope is that over time we can be moving more in that direction. And I want to share with you tonight a little bit about work happening in other places to sort of break down some of those barriers more effectively. So we're going to talk really about young people to a large degree, and this slide looks a little bit complicated, but what we're really focusing on is issues of age, from 0 up through the age of 80, and then these different layers really reflect the frequency of different medical conditions across the lifespan. And I want to highlight for you this particular area right here, which are the big jump and pyramid in medical conditions for young people really between the ages of 10 and 30. And what you'll notice is they really are, for the most part, mental disorders. That is the morbidity for our adolescents and young adults that is faced on a regular basis. So I think most of you maybe have learned by now, sort of a surprising statistic for many people, that half of all mental illnesses have their onset by the age of 14. And 3/4 of the time, they start by the age of 24. So when we really want to look at early detection and early treatment, we really are thinking about starting much younger than people think, and it's important to be able to do that. And then when we look at the number of people that don't access care overall, it's generally 4 out of 5. And there are many, many reasons for that. It's partially sometimes related to the stigma issue. For many of our young people, it may be related to issues of parents feeling blamed and there's uncertainty about whether or not to get help or how to get help. We have huge issues in terms of having a workforce with enough capacity and training to be able to provide people with care in a comfortable way. So there are huge, huge factors that are impacting this number, and we have a great deal of work to do to improve the possibility for people getting treatment. I've done a lot of work in schools, and these are our students sitting in our classroom, and they may be stoned or pregnant or working late shift or hungry or alcoholic, but these are us, and these are our kids. And here is our teacher who has an aging parent and is also going through a divorce. And we are working to build capacity for our students to be great lifelong learners, to be able to be successful academics, to go on and do wonderful things in their careers, but they're many times sitting in the classroom with these issues. And we often don't do a very good job of helping them figure out how to address these concerns, which is one of the reasons why school mental health programs can become very important, and understanding also how to support our teachers and our school health professionals can become very critical as well. When I often think about sort of the scope of programs involved in providing health and healthcare support across many spectrums, I think about this wheel that was put together by the Institute of Medicine that really looks at a whole continuum of support in terms of understanding sort of health-related factors. If you begin with notions of promotion, so say for example we're looking at an issue around obesity. So when we look at promotion, what we see now is information about healthy eating, how to make the right food choices, the importance of exercise in your daily life, and education about how the foods we eat impact how we do. We have a First Lady who's done a great job of supporting health promotion around obesity prevention. And with that, we see many other prevention models, universal for everyone, selective, maybe targeting a specific group. In New York, there was the very controversial legislation around how big the sodas could be, which is another form of prevention, really to then target obesity as well. And then we look at case identification and early detection. So within that frame, we might talk about BMI, body mass index, that people really didn't know about or talk about 15 or 20 years ago. That's become a critical marker in recognizing when things are changing in someone's body type. And then early intervention for those issues and early recognition, where we're building exercise programs, we're building treatment models for young people, all in an effort to combat our obesity epidemic. So we can also think about these kinds of models for mental health as well. And it's one of the things we're really trying to work towards. And it would involve, how do we get education out about early recognition of mental illness, the fact that mental health conditions start early. How do we build that education for our community and for our public to better understand those, to break down stigma, to help people have a better understanding of these issues? Prevention programs can range from mental health awareness in schools. Many of the schools now are building stress prevention programs for young people, are looking at ways of building mentoring support to deal with early stresses as well, looking at even meditation and mindfulness classes in schools, all as an effort to build sort of resilient, mentally well and healthy young people. And then when we're looking at case identification, do we have models for screening, for example, for early detection for mental health conditions? In some cases, because of the stigma, it's a very controversial question. Some schools may be comfortable with screening, many are not. Many parents don't feel like it's right to have mental health screening for their children. We have a world where when kids are in kindergarten, or coming into kindergarten, we do vision screening, we do hearing screening, we do no mental health screening, because what does that mean if we do it? And so, looking at models of early identification are important. We now have information about screening for depression from the U.S. Preventative Task Force, saying it's important to look at adolescents and adults around issues of depression and suicide prevention across multiple settings, but it's been very slow to develop those models. And then how do we look at the treatment and interventions, and what kinds of services do we wrap around once we identify young people with early signs of serious conditions? So one of the areas in which this whole frame is being developed internationally is this notion of psychosis. And when we talk about psychosis, what we're talking about is someone who has really sort of lost touch with reality in certain ways, where someone has very strongly held beliefs that they will hold on to in the face of sort of evidence to the contrary. And for some people, that might be hallucinations, hearing voices, seeing things that maybe no one else experiences or believe they are there, but that person is very sure they hear them or see them. It may be delusions or beliefs that maybe don't have a basis in reality, whether it's the ones we might know a little better, like paranoid delusions, where we might think that people are talking about us or saying bad things about us or things like that. But that loss of touch with reality in the face of factors that would, say that there isn't support for that belief really all fit with this notion of psychosis and losing touch with reality. One of the things we've started to learn, which really in terms of the training I had years ago around some of these psychiatric illnesses that have a psychotic component, is that recognizing psychosis very early and providing very early treatment can have a huge positive impact on people's outcomes over time in a way that we didn't really used to believe was possible. So for example, when we talk about psychosis, one of the things we often talk about is the duration of untreated psychosis, which is the length of time from when someone really has lost touch with that sense of reality and is holding tightly onto that belief, the period of time from when that happens till someone really gets involved in treatment. And we call that a duration of untreated psychosis. And what we've come to know is that for the most part, the shorter that time is and the earlier we can link people to treatment, the better people do 5, 10, 15 years later. People often need less medication as part of their treatment. They respond to lower doses. People can function better over time in school and work, have better socialization and social skills, and that really recognizing these issues very early really matters and can really make a big difference. However, when you look at the number, the average duration of untreated psychosis in the United States is often 1 to 2 years. That people can be struggling with these symptoms for a very long time before they're recognized. And when you think about the possibility of these symptoms starting before the age of 14 for young people, or very early in adolescence or into later adolescence, it gets very hard to think about then how do we do that intervention. So here's a quote from a young person who is developing psychotic symptoms that kind of highlights some of the difficulty. I'd say I started having paranoid feelings about a year ago. If I really think, things started to happen little by little, but they gradually got worse. I didn't notice because I thought the way I felt was right. And my parents didn't notice because it was so gradual. And that's part of what makes this sometimes difficult. And looking for those early symptoms then becomes complicated. And for young people sometimes who are developing these symptoms, they're keeping them to themselves for stigma reasons or fears that their brain might be playing tricks on them or wondering if something's wrong. Or then they may think, well, everybody's going through this, but everybody's going through it alone. And what I'm experiencing may not be different from what anybody else is, but boy, no one seems to want to talk about it. So one of the things that we've started thinking about in terms of this notion of duration of untreated psychosis is sort of what comes before. How do we start thinking a little bit more developmentally so that maybe we can provide support for young people before they get to the point of losing touch with reality? And we call that, for the most part, in this country, sort of the prodromal phase. Like we talk about the prodrome of a cold. You know, it's been a long day and you're starting to wonder, is my throat getting scratchy? Or you have one sneeze and you start to wonder, uh-oh, is this cold coming on? Am I starting to get sick? Maybe this is why I'm dragging a little more than I usually do this evening. And then you wake up the next day and you're stuffy and you don't feel good. And yes, that's what's happened. And we talk about that period early on where you're starting to wonder if those are the symptoms, really that prodrome of your cold. And in this case, we're really learning more about this concept of prodrome as it relates to some of these serious mental health conditions. So it's sort of this early period before one maybe is developing sort of their loss of touch with reality. The symptoms are often gradual. They're uncharacteristic for the person. The person may realize that something doesn't seem right, or they're wondering, is my brain playing tricks on me? Are those people really whispering about me, or am I just imagining it? Or did I really hear something? Or are these lights sort of brighter than usual, or colors more vivid than usual? People are starting to wonder if something's starting to change, but they're not sure. And it's scary. So I mentioned this a little bit. So the duration of untreated psychosis really, as we said, can have huge impact over time. And what we're trying to do now is wonder, so if we can help support young people with those very early symptoms, we're talking about intervention really where the duration of untreated psychosis is 0 or less. And so then what does it mean to provide that type of early intervention, and then how well can people do? One of the things that we see, and this is from our colleagues at the PEER program in Portland, Maine, this slide, is that as people have long periods of psychotic processes or duration of untreated psychosis, people are more likely to have decreased functioning over extended periods when people have multiple episodes of psychosis. Sometimes, when people have many relapses, it takes longer each time to recover. And so it's important often to try to minimize the number of times that people will have those kinds of experiences. So I'm going to share with you now a little bit of a complicated slide, but this slide is basically trying to highlight a number of things, which is sort of, well, what is the frequency if we can find young people early that are beginning to have symptoms but haven't reached this point where they've lost touch with reality? Well, how do these young people do when we recognize them? And do they move on and have these psychotic processes, or do many of them not do that? And these are a number of studies, mostly done actually in Europe, 1 or 2 in the United States. And for young people that maybe have been recognized as being at risk without getting treatment of any type, about a third, or 33%, go on to develop a psychotic process over time. With most of the interventions, though, where you have young people that you identify as being at risk and build supports around them to decrease stress, to provide ways of improving communication, to help support them in terms of school or employment, after that, maybe about 1 in 10 go on to develop potentially a psychotic process over time. So one of the issues, and frankly one of the areas that people have been struggling with internationally, is this sort of prodromal or pre-psychosis area an area that's worth evaluating, investigating, trying to find people early for? So this is one study that's a meta-analysis of a number of different programs. It's a little bit hard to read, but the point is here that for people who maybe have been identified at clinical high risk, approximately 18% after 6 months untreated were moving to a more serious psychotic illness. 22% after 1 year, and then 30% after 2, 36% after 3. So there's a sense that over time, if left untreated, people do have serious problems to the point where it seems important to identify this group and build supports for them. It's become a controversial thing in terms of whether or not we provide treatment. There are issues of what to do. This is a study from one of our colleagues. This slide is from one of our colleagues, Pat McGorry, in Australia, and it's frankly a slide about prediabetes. And the point he's trying to make is that when we look at prediabetes as a high-risk state, 5 to 10% of people who are pre-diabetic go on to develop diabetes over the course of a year. And if that's a number that's high enough to seem to be worth building preventive treatment for people who might be at risk for diabetes, why wouldn't 10 to 20% be enough to provide preventive treatment for people with a psychotic illness or at risk for psychotic illness? And I think he's trying to speak to some of the disparity issues as it relates to mental health conditions versus other types of medical conditions as well. I don't want to harp on this too much, but this is just one more study that came out last year showing basically that following people from a period of 2 to 15 years over time, this was a group of around 400 people, and about a fourth of this group over time developed a psychotic process over a period of up to the 15 years. In most cases, it happened in the first 2 years when people came into these programs, but a few people really even 4, 6, 8 years later went on to develop serious psychiatric illness without additional types of intervention and support. One of the ways that this is making us think a little bit differently about mental health conditions is this notion that if we really start to look earlier and look at how people are doing sort of in a functional kind of way, we might really frame things differently in terms of diagnosis. So it's not just does someone meet this list of criteria that are in this DSM-5 book, but what if we were looking at sort of early signs and even thinking about mental health conditions in a staged way, like we might think about other kinds of illnesses? And what would it mean if someone is starting to have maybe some early symptoms of stress, and then moving to periods where they're having some problems at school or other places? And we're building interventions by stages to build support for young people very early. And yes, some people will progress to the more serious stages and then require higher levels of intervention. But so, for example, we know that helping people who are maybe having some of these early symptoms that are prodromal respond very well to stress management and support. We know that even omega-3 oils, fish oil, there was one study, in Europe that really found that 3,000 milligrams a day of fish oil can help people in terms of treatment for psychotic illness. Well, what if people started taking fish oil very early in their processes? What if we worked on diet and exercise and other health conditions, and then maybe later on, if the symptoms get worse or people have more trouble functioning, then one might consider adding psychotropic medicine or more intensive kinds of interventions as well. But really thinking about illnesses in a staged kind of way, and maybe framing how we think about mental health conditions and support in a different way is something that's really sort of taking off in other countries that's worth thinking about a little bit here as well. Some of these look a little light and hard to see, but so what this sort of leads to is a mental health service reorientation. And what this big circle here says is informal and community support as the biggest circle in terms of support for young people, followed by semi-formal and formal gatekeepers and people who help recognize young people with early conditions. Headspace is a program I'm going to talk about in a minute that has support for people with a high prevalence of general medical conditions, and then more serious kinds of interventions for people when they develop early psychotic illnesses or high-risk kinds of behaviors in that way. So what we're really talking about is models that would frame that continuum of mental health support as well. This slide really is briefly from our colleagues in Australia, where they really looked at some of these different kinds of models. What if we support these young people with early symptoms, with stress management, with family support, with communication skills? And what we see here basically are costs. And the green is with the early intervention programs over a period of years, and the blue is with standard community care as usual. And one of the things we see over time, and these are over 8 years, is that the cost ends up being about a third for providing these early identification programs compared to care as usual, mainly because the rates of hospitalization really then are much lower. People are getting support in a more intensive way, and so financially there are motivations to do this too. So I want to talk a little bit about a program that I know I'm very excited about. that really sort of shares and frames, I think, in a really different way for us what these models might look like if we were really going to create a system in this country that would really look at targeting these young adults at high risk and building supportive models, really marketing to them and focused on our young adults to really do preventive support for mental health and other conditions. So in Australia, there's a program called Headspace, which are standalone health clinics that have health checks, sexual health support, health information, but the frame of them really is around mental health care and working to make mental health support comfortable for young people to go in and access early treatment and training. When we look at these programs, they're building models that are youth-friendly, that aren't judgmental, that have strong youth voices in terms of how the programs are structured. The program doesn't end when people turn 18, but really supports a whole transition age from 12 to 25 years of age that really are standalone places that young people can walk into or go in with their family in order to get support. These models right now are being financially supported by the federal government in Australia. They initially built 50 of these programs around the country. Now you have to realize that Australia as a country is about half the population of the state of California, right? So it certainly isn't as vast as our country. At the same time, they started with 50 programs like this. They've now built 50 more and are working on expanding this model because they've seen such success in bringing young people to care very early. When you look at these models, they're built in such a way to appeal to young people in terms of the design, in terms of the artwork, and are really trying to make them youth-friendly sites. What to expect at a center? Well, they have core physical health, mental health, alcohol, and other drug services, and really are an entry point for anyone. Now, certainly their health insurance system is different. They're very low cost. In many cases, these models are free. But again, the target is really trying to bring young people in for early support. What I want to do for a minute is just to give you a little bit of a feel of what it looks like when a country is marketing support for young people towards mental health. Just to give you a little sense of what these models actually look like. So here's a little bit about the Headspace program. And one of the things I think you need to keep in mind is certainly there is maybe not the diversity of the culture and community that we would see in this area when one looks at Australia. And those are the kinds of things we need to think about. But when I look at sort of what they're trying to do to market to young people, it really makes me think differently about the kind of care that we're providing at this point.
Sure, have a seat and I'll grab someone for you. What do you get when you're feeling depressed?
A heap of anger and a truckload of stress.
How do you feel when you sit here in this room?
Extremely nervous and impending doom.
Try to relax, you're in great hands. You see these people here, they really do understand. It's not very scary and it'll be just fine. And welcome to Headspace, Sunshine. First, you must see someone from the access team. They're helpful, cool, and never mean.
But what can't explain how I feel.
No worries, young man. That's no big deal. We can just have a chat and see how it goes, and soon you'll find it all just flows.
Despite his funny teeth, he doesn't bite. Trust me, I've been here. It'll be all right.
Well, I'm not sure if this place is for me. I have no money to pay a fee.
No need to stress, you see. Here at Headspace, most services are free. You can come here for any sort of trouble. Now let's break it down on the double.
Here in HS, we got the best of the West. From sexual health nurses to psychiatrists. We'll help you out with your problems, drugs to drink, or even if you need some help to think. We don't discriminate. We ain't here to hate. Word. Yeah, so next we're gonna go and see the GP. They're really nice and so not creepy.
Welcome, young man. Here is where we draw up your plan. From here on in, you'll be walking with a grip.
You get the idea, right? So, okay, it wouldn't work in many places around here. At the same time, I think the important part of it is sort of the frame of what they're trying to do and really working to build a focus to address sort of the young people in their communities to try to present these places as sort of comfortable and friendly places to come and get support. When you look at sort of the models they're using for marketing, Sarah versus the dreaded butterflies. If you're fighting anxiety, Headspace can help. Daniel versus the black cloud. Huge amounts of sort of marketing and tools designed to provide support. Australia has a big day out where everyone goes out and hears the most popular bands in the country. That whole program joined with Headspace this year to do a national cross-country motorcycle tour where some of the best bands in Australia traveled to a number of different countries with the national Headspace leaders to promote mental health for young people as something that was a cool thing to do. So these are the kinds of models that are being developed there. There's quite a major piece related to electronic support as well and online support. The Headspace CEOs have been spending time occasionally over here at Facebook talking with the people there about their suicide prevention models and the ways they're linking support to young people. When you look at their demographics, 37% of the people using eHeadspace are 15 to 17 years old. So they're working hard to sort of build out the model, and most of the support is around mental health and behavioral kinds of interventions. They have models at this point, as I said, across the country. Over there, the gentleman with the beard there is Dr. McGorry, who shared some of these slides with me, who's also been leading this national effort from the psychiatric perspective. And here was the person who was Prime Minister of Australia at the opening of a Headspace site. And so you see sort of the support of the government in building this. Here's the Irish version of Headspace called Jigsaw. And these models are starting to be built in Ireland. There are now 6 Headspace sites in Denmark, and they're starting in Israel. And the Canadian National Mental Health Commission is looking at these kinds of models as well. We're starting to see on an international level, this is a model, the International Consensus Statement about early intervention and recovery for young people with early psychosis. And we're starting to see on an international level an international declaration of youth mental health that's trying to really spark people to sort of frame a model of support that really looks at how do we build these systems of care in a way that will really link those young people to early services, because there's so much of a benefit that we're seeing internationally. This was the first International Youth Mental Health Conference in Australia in 2010. And here was one in Canada. Here was the one last year in the United Kingdom. that was really focusing on bringing young people again together from around the world. We now have a journal that comes out quarterly, Early Intervention in Psychiatry, where people from all over the world are putting articles out around this area. The International Early Psychosis Association has grown to the point where this is sort of the annual membership increases in the organization. All of this to say there's a lot going on. The next international conference for this group is in Tokyo this November. 2 years ago, the conference was actually in San Francisco. So this is a movement that really is growing. And when we look then at our country and see where we are, what we're starting to see, and this is from SAMHSA, the Substance Abuse and Mental Health Services Administration, which is our federal government's sort of public mental health system of support that provides our mental health dollars. They've started moving also as well in this direction. So this was one of the goals from SAMHSA from their 2010 strategic plan, building emotional health and preventing or delaying the onset of and mitigating symptoms from substance abuse and mental illness. We've had a number of programs that have come out of this country starting to look in this direction. The first two are from the National Institute of Mental Health, and RAISE is one that I mentioned I was involved with, and this other one, Naples, is actually looking at the young people with prodromal symptoms. And then Robert Wood Johnson funded this EDIT program around early detection and intervention for the prevention of psychosis. These models often, this is from the EDIT program, they have websites that try to be really user-friendly for young people. They have ads. I met the people from EDIT because they were the only other program I knew of from when I was coming from New Mexico that was putting slides in movie theaters when they used to have slides before they started showing videos around early warning signs of mental health conditions and what if it's not a phase, and what if your young person is developing a serious illness. The components of most of these programs around prodromal support, first of all, include a great deal of outreach and education so that people can come to recognize the early warning signs. The targets are usually schools, colleges, community colleges, and primary care settings. The screening and referral components, as we mentioned before, are critical. And the treatment really is focused on stress management. It's focused on improving communication at home, linking families to other families that are dealing with similar issues and young people dealing with the similar issues. And the multifamily groups have been really great as I've led multifamily groups because the cross-generational discussions that can happen are very powerful. While I might not be willing to hear something from my child that I might be doing, I might be willing to hear it from someone else's child. And I might be able to say something to another child that they can't hear from their parents in terms of things that are happening and how they're interacting, as well as then school and employment support, and then medication really as appropriate. RAISE is a model that is continuing to get a lot of support around this country, recovery after an initial schizophrenic episode. And RAISE is really focused on a study that built in community mental health centers, a model to really provide support for people that have a first episode of a schizophrenia-like illness. And within the RAISE program, there was a medication component, a family education component, supported education employment, and you sort of see the pattern of this, and then an individualized program for that young person to understand their illness, to think about strategies for coping effectively, and building on other support. We're seeing other states and around this country these models beginning to take off. This is Oregon. And in Oregon now, they started out within a number of counties based out of Salem, building on these early psychosis programs. And then they became an EDIP site and added a prodrome program. And the outcomes were so good that they went to the Oregon legislature, which has then now agreed to build these models across the health system in Oregon. And they continue to fund it in a broader way. What they've seen is that young people with these early signs are showing improvements in being able to be in school and working. The number of hospitalizations continue to drop as people come into these programs, and we're really starting to see tremendous support. Now in California, as many of you are aware, we have the Mental Health Services Act, which provides additional money for prevention and early support around mental illness. And what you see here is the counties in darker color are the counties that have one of these types of programs, either for young people with sort of prodromal symptoms or a program for people with a first episode of serious illness. We have very few that have both. And one of the things about being where we are right now, we're in Santa Clara County, which has the REACH program, which is a program for young people with prodromal kinds of symptoms. And the people at REACH were trained by the program in Maine that did the EAT program in these early signs. However, if you go about half a mile that way, you cross that bridge at El Camino and you're in San Mateo County. Well, San Mateo County has the PrEP program, and the PrEP program supports people that have a first episode of psychosis. But if you have prodromal symptoms, you can't go to the PrEP program. If you have a psychotic episode and you live in Santa Clara County, you can't go to the REACH program. And so one of the things that we need to start working on is how do we build these broader networks across our state, across our counties, across our country. And there's starting to be some movement in that direction. We now have at least the different programs across our state talking to each other and looking at ways of building common training and starting to look at even outcome measures to show the benefits of these programs. The people who are involved in the Mental Health Services Act on the state level are also starting to notice the benefits of these programs and are looking at expanding some of these programs across other counties and really encouraging that. On a national level, this is an article from the Journal of the American Medical Association, and this is an article written by our current president of the American Psychiatric Association, actually saying this last summer, we need to do a different model for identifying and treating people who are developing schizophrenia. And it's time to really start shifting to an early intervention model in the United States. We're seeing articles about, well, how do we finance these first episode programs in a country where the financing is very complicated for mental health? And then even in terms of the popular literature, this is from USA Today, this notion of early care for psychosis is actually starting to be discussed and acknowledged in a pretty new way. One of the exciting things that happened this last spring, when the federal government completed their budget plan, they put into the budget bill additional money for every state to have an additional 5% in their mental health block grant for early psychosis programming. It's sort of not happened before. And so now every state is going to be looking at how do we build at least one of these programs. It's not often a large amount of money that they're getting as part of this block grant, but every state now has the option of doing a plan to start building these kinds of programs into their state system. So that's a very exciting piece of the puzzle as well that's changing. So here at Stanford, we are really, I would have to say, catching up a little bit in terms of building our continuum of support in this direction. I've been seeing young people with these early signs. We have an additional psychiatrist on the adult side who's going to be coming with this focus area over the next few months. We're building out a support for additional psychologist support and other mental health providers to do broader training in the psychosocial interventions for early psychosis. The Headspace program that I mentioned, we made a proposal to the Robert Wood Johnson Foundation to consider looking at Headspace in the United States, and found out this week they are giving us some funding to, along with Headspace, do a feasibility study of what it would mean to implement that model in the United States, to look at some of the finance issues, some of the marketing issues. So we're excited about that. We're starting to build on the connections between some of the different states, and are now, we're focusing on building a national network of all of these programs to try to build common support and communication, to get the data, to get more dollars, to build out these early interventions and supports. So one of the things we're seeing is an international field really developing of youth mental health that will have this focus. And our hope is, over the next 5 years or so, we can really be shifting the culture of mental health support around early detection, early intervention, in a way that really will help many of our young people stay on track much earlier and get them and their families the support that they need. So I'm going to stop there and take questions. Sir.
The basic question in this field, it seems to me, is that there is no fundamental quantitative diagnostic technique to detect whether the patient has schizophrenia, bipolar disorder, or depression, or what have you. There are no something akin to blood tests or brain scans that can be used easily and tell quantitatively that, okay, this Jane Doe or this Joe Blow has such and such mental illness.
So the question was, the issue that we actually don't have formal blood-related or other structured diagnostic measures around these specific mental illnesses to diagnose them correctly and appropriately. And you're absolutely right. And certainly while we are looking at building out models of support, we're also seeing the efforts to build out those models in a better way in terms of genetic support, in terms of other support, in terms of looking at different sort of blood as well. I think everyone would agree with you it's a big issue, and there's a lot of work still to be done in terms of developing that. You're absolutely right, but I think the other part of the issue is that there are some common symptoms, and even when we're looking at psychotic illness and looking at people losing touch with reality in different ways, it's not, there may be interventions that may be just helpful to everyone early in that process. And to some degree, I would say that as I've been working with young people with a variety of different mental health conditions, there are some times where they might move towards needing an appropriate sort of medication based on their different symptoms. But a lot of the early support we're talking about can be very helpful in terms of managing symptoms, I think, if we build those earlier. It doesn't certainly negate in any way the importance of building better markers and the effort to do that. But at the same time, there are other things we could be doing earlier that might also sort of lead to much better outcomes as well.
Actually, this was my question also, but I also want to ask, how do you differentiate? Is it, I don't know what, first question, what do you mean by psychosis? Psychosis is common for all this mental disorder, or it's a diagnosis psychosis?
So the first question is psychosis common across all mental disorders, and what is it actually? Psychosis, right? So psychosis is common actually at times in about 3% of the population.
So this is illness itself, psychosis. It's not schizophrenia, not bipolar, it's psychosis.
What we're talking about when we're talking about psychosis is people having early symptoms of what may turn out to be a bipolar illness. It may turn out to be a major depression with psychosis, or it may turn out to be a schizophrenia spectrum illness, or it may turn out to be, if we're looking at people in the very early phase, an early phase that's not going to become any of those. And so part of the issue really becomes, if we're looking at people with those early prodromal symptoms, well, how do we provide support for people to maybe keep them from moving farther in any of those directions? And so they really could be moving into any number of different conditions, but they have some commonalities early on that we're trying to address and decrease before they might move farther along that continuum.
So this means by psychosis, you this is kind of person who displays some abnormal reactions, abnormal behavior at this point. That's what you call psychosis.
So, as I mentioned before, some of it is a set of symptoms where someone may be hearing voices or maybe having thoughts that are confusing, but they may be doing it very quietly. And they may not be, that person may not be exhibiting outward behaviors that someone else might even recognize. Because often, we're all experiencing internal processes. So it doesn't mean that someone is sort of necessarily acting in public any particular unusual way, but they may be having thoughts that are confusing or scary or uncomfortable for them.
So is this a necessary attribute of mental illness, hearing voices, or like a person who just you think does not react adequately on the situation? I mean, having explosions. So this, how do you differentiate between real mental illness, or maybe it's a personality trait? That's.
So the question was, how does one differentiate between a mental illness and a personality trait? Well,
Just some kind of personality who just react,
Well, it's a simple and very complicated question, I would say. And I guess what I would say to you is that when I'm trying to, the whole spectrum of psychotic illness is just one group of potential mental health conditions. People may develop serious anxiety disorders, post-traumatic stress disorder, other types of mental health conditions where they might not necessarily be losing touch with reality as part of their experience of their illness. I think, for me, what I'm watching for, and there are times where, a number of young people come to me with their families with this question of, well, Johnny hears a little bit, hears a voice sometimes, and should we be worried? And someone said maybe they have schizophrenia. Do you think they really do? And what does that mean? And I think, the things that I get concerned about really are functional changes. To what degree is that person no longer able to concentrate and focus in school? Are their grades changing? Are their socializations with other people starting to change? But there's some shift of pattern in that person's interactions, behavior, self-care, those kinds of things. And even within that person's thought process, when I spend time with that person, if their thinking is clear, if they're being able to follow along things well, if they're doing well with their friends, then I'm not so concerned necessarily. So for me, the functional aspect of how someone's doing with their symptoms really matters in terms of looking at how serious their condition might be. Yes.
So, not that you're prepared for this question today, but as you know, the original topic was new things that are going on and being looked at. So if you could share anything in that area, it would really be appreciated.
Well, let's see. So what would be some of the new things? I think I think if you had the presentation tonight, there would have been more of a focus on some of the imaging studies that are going on. I think in terms of looking at some of the focus areas as well, I think some of the, again, sort of more of the genetic kind of focus areas and some of the newer medications that are potentially coming out. I will tell you that right now, my focus is not so much on the cutting edge of that, but how to support people sort of very early in their processes. So I think we're going to have to get our other presenter here to kind of give you the information you'd really like, and I apologize for that. Yes, ma'am.
Schizophrenia, do you have a list of symptoms and signs of
The question was, do I have a list of symptoms and signs for schizophrenia? Well, there are many. I'm trying to think, how would we share one with people?
We have them at NAMI, you can call us.
So at NAMI in Santa Clara, Kathy Forward, who is our lead person there, right, can help make that connection for you to get that information.
We have a chart that describes all.
Yes, ma'am.
Are you able to give us a medical opinion on the drugs currently on the market for schizophrenia and your opinion of what's effective and what's not? Or your view on that? Or in addition to everything else, we do everything else.
So the question was, would I be able to give you my opinion on the medication that's out there for schizophrenia? I guess you know, there are many different medications. There are sort of newer ones coming on the market as well. And I guess the thing I would actually say is, and, you know, I am not involved with any drug companies, you know, at this point. But I think the one thing I would say in relation to the medication issue, and it's not around specific medications, it's sort of this notion of how medication is being used. And one, I don't know how much you look at online at different websites and different groups in support of people that are facing different mental illness related issues. But one of the things that I think is changing in how we think about medication is that we really used to think for a period of time that when someone started right on a medication for schizophrenia-like illness, they really needed to stay on it on a related dose for a very, 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 very long time. And I think right now, one of the things as I sit and look at a lot of the literature and even a lot of the dialogue among psychiatrists around the country, one of the things that's really changing is this notion around the use of medication over time. You know, people talk about start low and go slow, but I think that's even resonating more with people now than it ever has before. And I think what we're starting to see is shifts in patterns of prescribing and use of medication. I think people used to believe that you shouldn't recommend stopping antipsychotic medication for people. And now I think there are some concerns that maybe longer term use can lead to more difficulty over a long time in terms of cognitive functioning and outcomes over an extended period. And so more and more, I think we see people really recommending people staying on a lower dose, looking at tapering off medication for periods of time and see how people do. I would hesitate to say, though, use this medication, don't use this medication. Certainly the side effects that people are facing with the second generation antipsychotic medications, you know, remain a complicated factor. And I think many programs are doing better jobs than others around monitoring for changes in terms of weight, blood pressure, blood sugar over time. And those become very, very important to do and to build those structures in to care for people. But I think I'd leave it at that. We have, 2 more minutes? Sir.
What you talked about is not only for schizophrenia.
Right.
I mean, that can deal with all forms of mental illness. That the sooner you get it, the sooner you start treating it, the better the outcomes along, you know, in the future. So it's not just schizophrenia.
So the question was, you know, isn't what you're saying about sort of early detection, early intervention true for every sort of mental health? Well, really, it's true for every health condition, period. It's basic, but I think we really haven't thought about the potential huge impacts that can come from early intervention around many mental health issues. You know, as someone who works as a child psychiatrist, even looking at the issues around attention deficit hyperactivity disorder, and what does it mean to diagnose that properly and early and link young people and families to early support. Even looking now at autism spectrum illness, it seems very clear that the earlier intervention happens for children, you know, with early signs of autism can have a huge impact on outcome years later. So it just sort of is consistent with everything else. But it's still really different from how we've thought about mental health issues to this degree. And the fact of how much earlier symptoms are developing is really different. One last question from the back.
I had 2 comments. There's a show, there's very few shows on mental illness, but there is one. There's one on Channel 7, it's called Black Box, you may have heard of it.
Yeah.
And it's about a woman who is bipolar. And it talks about her, if she's not on her medicines, what happens to her. So you might check that out. It's on Thursday night, tonight, on Channel 7 at 10 p.m.
Black Box.
Then there's another thing. This is really prevention. I work at a mental health hospital.
Mm-hmm.
I'm a dietitian, and someone handed me something, I haven't read the article, about choline being given to someone who's pregnant if they have a history of mental illness in their family, and how it might prevent schizoaffected disease in someone, in the child. I thought that was very interesting. I don't know if you've heard anything about that.
So there were two things related to the question and comment. One is the TV show about someone with bipolar illness called Black Box, and then the other really is the use of choline for people who might be in their pregnancy to help prevent the additional risk of schizophrenia. And no, that's not something I really have enough experience to comment on as well. Right. Okay. Well, we're going to stop at this point. I'm glad to stay here and visit with folks. Thank you very much for your flexibility tonight in terms of not getting what you expected. And thanks for being here.